Thank you, Pramuthi. That was really very exciting to hear it all come together. Um, I suppose there's only been a few questions so far, so keep them coming. I think really about half the questions at the moment are looking at this idea of, why join ASOP when you could join the college, or, do we run the risk of, where do we fit in terms of AMA, college, sane, other groups like that? Like what are we adding?
Does someone from the board want to take that question? I'm happy to give that a go to begin with. Um, so I guess this is a natural part of the landscape in all other medical specialties where you have a college, there's a very specific role, there's an advocacy, a body, a society which does more of that advocacy work. And clearly, the AMA report from today shows that there is a lot of work for us to do in the profession, not only in terms of improving the quality of care of patients, but a big part of that is also raising the profile of us as a profession. And so I think that's, where we fit in is being an organisation that's purpose-built to do that work. There's organisations like the AMA that do wonderful work in terms of the broader medical profession, but clearly there's very specific things that need to be done in the mental health space, which is where we would come in. I'm not sure if
Right.
anyone else wants to add to that.
Yeah, cool.
So I guess from my point of view, the biggest questions are around our relationship with the college, and I would want to say I think a couple of things. The first thing is that we are very, very keen to be working collaboratively with the college. We definitely see this as something where more voices are stronger, not weaker, and that we really want to put that alongside what the college does. But I think that the big difference that ASOP will do is that it's a dedicated advocacy organisation. So college has many priorities, is spread across, lots of areas. And it's really difficult for college to actually focus on the advocacy issues. I'm not saying they're not doing that, but it's just that what we will bring is a team that is dedicated to advocacy with people who are employed specifically for that purpose and that purpose only.
I mean, a thought I've got is how, and this is probably particularly relevant in Victoria, is that we need to sort of get back on the front foot as to the role of doctors, us being doctors in the field of mental health, and why that is a valuable thing. And some of that, involves grappling with complex constructs like mental illness and such like. But just not many people will know this, but we came reasonably close a few years ago in Victoria to having a new Mental Health Act, Mental Health and Wellbeing Act, as it is known, as it ended up being called, that entirely removed all reference to medical conditions. It completely demedicalised the new act, and that was a draft that was sent out to the public, that was being very seriously considered by government. So, it's easy to forget how far we've gone down the route of completely demedicalising the challenge of mental illness, and I'd hope that that's something that ASOP can lead on along the lines that your presentation suggested, Rudy.
Okay, we might go to another question unless any of the other board members would like to speak to that. So there's a couple of specific questions about issues that, we may not be able to give total answers to, but maybe would be a good sort of jumping off to how we might approach issues. Arjun's asked that ACT is now the lowest paid public psychiatrist in the country. Registrars are not being paid according to job role and instead by PGY level. Do we have a way to move this, partner, collaborate? A lot of registrars are really afraid to speak out. They're worried their contracts will not be renewed. Like, is this the type of thing that ASOP could be involved in?
I guess that's something that we would need to, I guess I should start off by saying, we want to be really strategic in the campaigns that we choose. And that's something that we will have to canvas in terms of what are all the different issues that are occurring at the local level, and then create a plan to step through what do we tackle first, what are the broad campaigns that we want to run, and then what are the more local ones that can add to that. And I guess we also would want to work with the different organisations that are already in that space. And I guess when you're looking specifically at remuneration for junior doctors or registrars, ASMOF would be the natural sort of organisation that sits in that space. That's not to say that we can't play a role in terms of highlighting what psychiatrists do, highlighting the important work that occurs in the public sector. So there are ways that we might be able to work together in doing that. But I guess there are, in terms of specific industrial issues, we wouldn't be a registered industrial body to be able to specifically look at that, the pay part of that.
I think just to add to that from my perspective as a registrar, one of the great things we saw in New South Wales was that, our movement in New South Wales was really driven by all of the psychiatrists and registrars working in New South Wales. It wasn't just a group of 10 people deciding that they were going to take something on. It was actually the whole workforce working together to collectively highlight the issues. And I know, from the work I did with David in the media, that we really relied on people being able to identify, well, what is the local problem that we are facing right here? And even if they weren't comfortable being able to advocate for themselves, they could pass information to us, and we could really work together to create a very grassroots movement for change that actually spoke to really local issues. And so to me, that's why I decided to join the board of ASOP, because I wanted to be part of something where, we're not just a representative body, we're actually part of a movement where we're all working together.
And I think you're right, Amy. I think one of the other things that I think we could do in that space is to be able to provide that advocacy training. And so whether it's, the media training or organising, there's all sorts of stuff that we can do to try and empower local psychiatrists and trainees to tackle those local issues. Because, we won't necessarily be in every space, but part of our remit is to build the capacity across the board in terms of allowing, building the spaces for people to be able to do that advocacy in terms of what's important in their local pockets as well.
And just to sort of put on with Ajit's written something in the Q&A, I mean, I would see that we could operate that way, that when there's lots of divided people or different organisations, how you can pull people together and see how they can work together in a complementary way so that it's harmonious and you can get something done. So again, if we think about, not to talk about New South Wales so much, but if you think about, you can think about where ASMOF fit and where the AMA fit and where the college fit, navigating that and connecting, we'd want that to be a strength. So collaborating and getting networks and joining people together would be a big part of advocating.
I think there's a question in the chat which I have just lost, which was about the importance of engaging with lived experience communities and how we intend to do that. Here we go. It's from David. He said, it's one of the foremost specialties that has a survivor movement. So how are you going to connect with the international and Australian critical psychiatry networks? So I think maybe, I don't know if Sarah would like to speak to her thoughts on that, and if anyone else on the board would like to talk about kind of partnering with people with lived experience and how we see ASOP's role in that.
Sure, I can start. So I think one of the core things around, from my personal own lived experience perspective and what I've seen in the advocacy that I've done in New South Wales in the last 10 months, is the lack of collaboration between the consumer peaks and other lived experience bodies with to engage and work with psychiatrists. So that was a really core part of why I've joined the board is to be able to have that gap between the lived experience community and peaks, and enable a conversation to start, and a collaboration, and to hopefully be built on and continue. Does anyone else want to answer?
I'll just make a point on the lived experience issue, that it is astonishingly complex. I mean, and thanks, Sarah, for that viewpoint. I totally agree with what you're saying. That my own experience of running a small training company, and we've got a lived experience consultant who works with us, because she works alongside psychiatrists at the college and with us and such like. She's had to remove herself entirely from social media because of the negativity that she suffers as a result of that. So it's a really tricky area. And just looking at a few different websites from different peak bodies in different jurisdictions a couple of days ago, it's clear that, Victoria has, there's one perspective that is strong here, there's another perspective that is stronger elsewhere. So definitely it's clear that we need to be in there. Lived experience has got a huge amount to offer, enhancing mental health services worldwide. But we need to go into this with our eyes wide open, and and be clear about what our boundaries are and such like, and be respectful and all the rest of it. But yeah, absolutely, we need to be in there collaborating with lived and living experience. There's a question from Ruth Vine that I might just take up. Around, because she's particularly flagged issues around Victoria and post-Royal Commission, how a lot of the funding was diverted to non-major mental illness and non-bed-based models of care, which I'd certainly concur with that. What that flags for me is, in this body, is for something around grappling with what exactly we mean by major mental illness, and also that other construct of what we mean by bed-based models of care. I was in Europe recently. It's staggering how low our bed base is. The OECD average is in the 60s. Belgium, which has a lower GDP per capita from us, is like 160 plus. I wandered the streets of Antwerp and Brussels and didn't see a single person obviously afflicted by acute mental illness. As soon as I get off the train every morning in Flinders Street in Melbourne, I see a lot of people clearly afflicted by acute mental illness. That's clearly telling us something. But we need to be quite flexible around how we think about beds, clearly, and think about things like supported accommodation, supported residential facilities in the community and such like. So it's that kind of complex, innovative, thinking and grappling with the key concepts involved, and I think ASOP can play a bit of a role in over the moving forward. So that's my 2 bobs worth anyway. Thanks for listening.
And Andy, just to add to that, I think I think, we're all psychiatrists and we know that, most things are relational. And I think, I'm hoping that as a body where we can really humanize who psychiatrists are, we can really reach out and work with lived experience groups. We can speak to, bureaucrats and politicians and government in general to try and kind of talk through, what is it that our patients experience? What does severe mental illness look like? And trying to really build those relationships so that, we aren't painted as these kind of orchestrators of the Mental Health Act that are just there to give depots to patients, and really change the narrative around, what is the role, what do we do as psychiatrists, who do we care for? And I'm hoping that would mean that we're able to reach out and work with lived experience groups with that really human focus. And potentially we can also shift the dial in terms of policy and government as well. If we are seen as a trusted group of people who are real and authentic, and they can turn to us, and we can provide them with advice and expertise and armed with data. I think, if we can flip that around so that we are this really responsive human body, then hopefully it means that we'll have better relationships across the board in all these different spaces, so that we can make sure that funding isn't going to non-evidence-based options or specific individuals and groups, but rather it's going towards core mental health care. And we can look to international examples like you've outlined. One of the things that was staggering during the New South Wales experience was that we had some international experts that came in to try and provide some options for various things, ways in which the New South Wales mental health system could reorganize. And what that really showed was that there are so many things that we just don't even offer in terms of therapies in Australia that are offered internationally. And so these are all things that we can speak to.
There's another comment here from Ruth in the Q&A, and it goes to the topic of the relevance of ASOP as being seen as national and the slightly different as well as common issues in all jurisdictions. And a common issue is getting the balance right between psychiatrists as drug prescribers and as skilled practitioners who are able to have a deep understanding of a person in their world. Hear, hear. That's exactly what we're trying to do.
And Beth, if you don't mind, and Pramudi as well, just to add, I mean that's a really important point, Beth. That Pramudi, you use the word to humanize, and one of the things that we noticed in terms of a lot of the media that we generated over the past 12 months is the feedback from the media is how struck they've been by the psychiatrists that we put forward and the human stories that they told, and also patients, loved ones sharing their stories, and what a transformation that's been. Instead of just being handed statements or pure data, there were really real talking heads. And even that example that Andrew just shared then about the difference, I think you were talking about Antwerp and contrasting it to Melbourne. Those kind of stories, what you just shared there, Andrew, are very graphic for the public to understand and to digest. And I think I hope I can speak for all the board. I'm not on the board, but we'll be handling media engagement and story, showcasing what we're doing, and that human difference is really important. That's how we got a lot of the cut through that we've driven. And as far as I'm concerned, and I think I can speak on behalf of Pramuthi as well, that would be a point of difference with ASOP, to really take that time to humanize, to showcase, and to, in the process, destigmatize. I think that will be a big point of difference for us.
And just to speak to Andrew's point around benchmarking, Antwerp versus Victoria, I guess within this consortium and national approach, we can also look to things like evidence-based medicine around clozapine. So some states may have low clozapine prescription rates, other regions may have higher, and we need to then understand, are there kind of epidemiological differences? And then probably brought up the example of registries, and then we can then cross-correlate with incarceration rates, homelessness, etc. But in an ideal world, people should start on clozapine if got treatment resistance, but we need the time and space and infrastructure to start clozapine, continue clozapine, and then work out the outcomes, both like health outcomes and mental health outcomes of starting clozapine. So that's an example where we could have a benchmark for clozapine prescription in Australia, and to what extent that compares with international best practice. And that's, I think, the advantage of data-informed practice rather than myself having to speak to Steve Kisley and ask, what do you do in Queensland? I'd wanted to have a conversation that's data-based.
I mean, there's even really basic things that we don't collect. Like, we don't look at mortality in psychiatric inpatient wards. I think the only one that I've seen is in Victoria. Over a decade ago, the Chief Psychiatrist's Office did a study on that. But beyond that, even really basic things like how many people are dying in inpatient wards, we don't collect that kind of data. And so I think, you know, there is so much room for us to be able to do that data-driven advocacy.
Just one last point on the beds argument. I've sort of done a little bit of work on that space. Like there's international consensus and a Delphi consensus study around 40 to 60. But as we all know, what is a bed and the types of beds, subacute, non-acute, residential, acute, short stay units, PICUs. And so I think there's granularity and clearly local differences. And so you can't say 40 beds per 100,000 for everyone in Australia. And so there's a degree of detail and sophisticated design thinking that needs to come into play to work out what a region might require, which is differentiated than a state average. And then the mix between private, public, and subspecialized beds. So I think we can apply some broad understandings, but the specifics need to be nuanced according to sociocultural variations.
Just with Victoria, the mortality data still very much is collected. So, but I think, you know, the trick is going to be making that, you know, advocacy point about the awful 15, 20-year life expectancy gap, which again is something that is absolutely shocking, but hardly anyone knows about it, you know. That's really important stuff.
Can I
just say that, I mean, I've seen there are a lot of comments about, you know, what are the directions and the priorities, etc. And I think the important thing is that it's the membership that determines those. I mean, you know, I want this board to be supplanted by an elected board as soon as possible, because it's the members that will actually dictate what the priorities are, not a bunch of self-appointed people who want to do good. And it's important to realize how difficult or how easy is it to influence college policy. It's actually pretty difficult. In fact, it's very difficult to influence college policy. Whereas this sort of structure gives a much more meaningful voice to psychiatrists in the field. I just wanted to add one further thing about there's a crisis in terms of the service workforce, but there's also a crisis in terms of clinical academics. You know, clinical academics are the people who create the new interventions and the new treatments that help improve the life of our patients. So I think it's really important to think that we're not dictating what the priorities are. It's up to the membership. And, you know, as I said, the sooner the appointed board makes way for an elected board, the better.
And there are a couple of questions there about the process of getting people on the board. Will we allow people with specific skill sets, like financial and legal skill sets, to join the board? I don't know if Pramitha, you want to just answer that briefly.
So our constitution does allow for that. And I guess at our first strategy meeting, we'll need to sort of develop a skills matrix and understand where the shortfalls might be and how we might be able to fill those, whether it's with appointed directors or, you know, whatever other mechanism we would utilize to be able to do that. So yeah, our board doesn't necessarily need to be full of psychiatrists. We have the option for it for other skills-based individuals to also be part of our board. We have the wonderful Sarah, who's on our board. We've got a trainee who's on our board. And also in terms of, I guess, just noting that there's no real difference between trainee and psychiatrist members with ASOP. Everyone's got voting rights. Everybody has an equal say in terms of what occurs within the organisation.
And are we a charity, Pramitha? And Kate's just asking, one of the limitations for the college seemed to be its charitable status. And so is that a kind of limitation we're going to face as well?
So the way that we've done our constitution, we've engaged lawyers who've made sure that our constitution is DGR ready and ACNC ready. So we could become a charity, But I think we're going to need to work through the pros and cons of that, and that'll be something that we would work with the board to do in terms of just understanding that better. And if it is that it hinders our ability to do this work, which particularly political advocacy is something that charitable organisations can't engage in, then that may not be the pathway for us. But we've just ensured that our constitution is written in a way that allows us to have both options open.
I think there's a couple of questions there around this idea that, we as a craft group have become quite fractured. There's one about New South Wales, but I think there's there was another question too about the fact that, sometimes it can be hard to get people to engage with the college, that, there's this sense that it's quite monolithic and that, it's conservative and there's nothing people can do. And I'm just wondering if anyone on the board has any thoughts about how we begin that process of engaging rather than disengaging, and kind of connecting a workforce that's quite fractured and people who are working in very different ways, public versus private, all of those kind of issues, how we approach that as a group.
So I guess there's two ways that I can see that we might be able to push forward in that. The first is that the first thing that we really want to do is run these 2-day advocacy workshops around the country so that we can hear from members in terms of what are the core issues in each of the jurisdictions, so that our work is informed by what the members what's important for the members. So hopefully that's just like a really practical way to be able to engage people and to understand what the main concerns are, to pick the themes then that occur across the country and what are the ones that are specific to different jurisdictions, so that we can plan our workflow in that way. And the second thing I think is that, one of the things that we're really excited about is running lots of events. And we've got ideas for, fun things that we can do, evening activities, other types of workshops and things like that hopefully will be able to bring us together. Because I think if we're able to connect more as individuals, then I think that's going to help us become a stronger group, so that we can work together. I mean, that's certainly been our experience in New South Wales, that this issue has really brought everyone together and there's this real sense of community. And I think from that, we're able to do a lot more together. And I'm hoping that we can bring that out across the country in terms of having those touch points and those places for people to come together.
And as I said, when were you ever able to feel that you could influence college policy? I'm hoping that this will be a much better way for psychiatry to be able to influence policy and advocacy.
I'd also perhaps make the point that, psychiatry by its nature is and always has been multi-voiced. If you want 3 opinions on something, ask 2 psychiatrists. It's quite straightforward. And I think that's not necessarily a bad thing. I think maybe something we can think about is how we can learn how to disagree better and more respectfully, and gain something from the dialectic rather than just kind of packing our toys up and going home sort of thing. I think for all of our disagreements, in terms of the Venn diagrams involved, there are huge areas of overlap. And I think there are things on which we can all firmly agree on. And then there are things on which we're probably never going to quite reach anything approaching a broad consensus on. And kind of that's okay. And I think we have to own the possibility of disagreement and some degree of diversity of views, and not see that as the end of the world, but obviously maintaining focus on some really big ticket, really important stuff where we can all pretty much agree.
There's a question from Anthony Harris. A strong organisation needs a financial basis, especially if it's going to advocate across multiple states. How is that being approached? I may have missed that in the presentation earlier.
Anthony, I guess the first thing we need is members. And I think that's what's going to keep us independent and ensure that, we can continue to do this work for the betterment of our profession and for the people that we care for. So I'm hoping that if people who are listening today, if this is something that you want to join and you want to spread the word, that would really, really help in terms of really building a critical mass. So I think that's the first thing, is around membership. And then the second thing is around events and things like that, which might also help with revenue raising. And from there, we'll have to think about, what the other options are. I know some of the other societies, when they develop things like registries, they're able to utilize that for revenue raising as well, in terms of working with universities or other groups that might want to run studies and trials and things like that. But we're nowhere near close to being able to kind of figure that part of it out. So I think that's going to require a lot of thought in terms of what are the pros and cons and how do we step that out. So I think initially it's really about members and events, and then going forward from there, hopefully we'll try and find ways to increase funding that still allows us to be independent and member driven.
Okay, we're almost out of time, but I'll just quickly ask the last question, because Arjun's come back and pointed out that I ignored his question the first time around, or didn't get a chance to ask it rather, and asked me to ask it, which is about conflict of interest and ASOP. So, the fact that in the college, most representatives are in the public system and are paid in their public sector roles, and then his perception is that those people aren't able to criticise their own health services, and in fact they're paid to do the opposite. Is ASOP going to suffer from that same conservatism and that same, I guess, conflict, causing it to be unable to criticise the public system or make waves when it needs to?
I guess in terms of an organizational structure, I don't think so. Like, we're not, there's no special relationship that we need to have with the government. They don't hold the keys to whether we can, do our work. So I think, all colleges struggle with that in terms of requiring a relationship with government in order to continue to be the training organization or to continue to provide CPD and all those sorts of things. We're not, that's not something that's going to affect us. And in terms of the individuals who join, I guess, we're all going to have different conflicts. That's just, we want people who are engaged in public work, in private work, in NGOs and all sorts of spaces. And by that very nature, you're going to have different conflicts. And I think as long as those conflicts are open and they're managed, then I think, that's the way that, any organization would work on that individual conflict basis. But as an organization, I don't see that we have significant conflicts.
The other thing I would say is that, I think, if you work in the public system, you have to be a little bit careful about your own health district. But I mean, we're not going to be intervening at the level of health district. We're going to be intervening at the level of, the whole system. So I think that's less of an issue than people feeling vulnerable because they're, criticizing their own particular hospital. I don't think the idea is to get down to that sort of micro level.
I think those connections also give us a really special power and a special responsibility to speak up and advocate through an organisation like ASOP. And certainly my experience in the New South Wales crisis was we wouldn't have had anywhere near the amount of buy-in and leverage we had in the media if we didn't have people who were willing to share information about what things were like on the ground. That, that was actually really key for us. And I think, having those connections with the academic world, having those connections with public hospitals, having those connections with private allows us to be very flexible in the state and in that way, and also to really share information with the public that the public, ought to know and wants to know and is interested to hear. So I think that it's a power as well as a potential conflict.
So I think we might be running over time, Amy, is that right? Yeah. So, thank you, everyone. This is just the first hello from ASOP. And we're really looking forward to starting the work, to reaching out, and to making sure that what we do is informed by our members. And so we will continue the conversation. And as updates occur, they'll come up on the website. I also just want to let all the people that have already joined, thank you so much for joining. It is incredible the amount of support we've got on day one. You would have put your email addresses in when you joined, and we're going to send forms out to everyone in the coming days so you can put in more information, because I know a couple of people have reached out to say that we didn't put any demographic information, but that's coming. So we'll reach out to you and we'll try and gather all of that data. And please check out our website. There's a lot more information on there. Our constitution's on there. That should provide you with more information as well. And we're really excited to work in the space and to try and hopefully bring about some positive change in mental health, which is much needed. I think if today's report and all of our experiences would show that. Thank you, everyone. And I'm going to close the webinar. Hopefully I can do this.